Hello and welcome to our podcast Pager. I'm George Milner.
And I'm Stan Dale.
Tune in to hear us talk with some amazing people about the subjects changing medicine today. In this episode, we look at what palliative care means today, and we unpick some of the misconceptions that may be held by patients and healthcare professionals alike. What is important at the ends of our lives? How can emotion be both a doctor's friend and foe? And how can people prepare for the challenges faced as medical advances redefine what is possible in end-of-life care, though not necessarily desirable? We're joined by Dr Stephen Barclay, a GP and honorary consultant in palliative medicine in Cambridge and Peterborough. Dr Barclay is regularly involved in both palliative care teaching and research, as well as hospice work in the Cambridge area.
Thank you for joining us, Dr Barclay. How are you doing today?
I'm fine, thank you. Yes, and yourselves?
Not too bad,
Good.
thank you. Yeah.
Good.
Doing very well.
Good.
So could I start, if I may, by just asking what do we mean by palliative care today?
Palliative care has a number of different definitions, but essentially what we're talking about is the care of patients in whom the illness they have is progressing. Time is not on their side. We can't, unfortunately, cure their illness, but there's always plenty we can do in terms of making sure that the time they have left is as meaningful, as comfortable as possible. And it can go on for months or sometimes years.
How disease-specific are the components of palliative care?
It was born out of concerns for cancer patients who were experiencing care towards the end of their lives, particularly with bad symptoms, particularly bad pain. And that's what the UK hospice, or the worldwide hospice movement, grew out of. It's moved much more explicitly to include the majority of people who die from non-cancer illnesses, and who frequently have very heavy symptoms that can go on for quite some period of time. One of the challenges of the non-cancer agenda is sometimes it's a more unpredictable period that people have in the final period of their life. It's a little bit more predictable with cancer.
Obviously, this is a very sensitive topic, even for doctors to be dealing with. And I imagine there are quite a lot of people in the medical community who shy away to some extent from dealing with this. Do you think that this is a problem in terms of incorporating palliative care into the broader context of healthcare?
I think it's a huge problem because no one likes talking about some of these issues. They're challenging, they're difficult. They often key into the doctor or the nurse or the social care colleagues' personal experience, and no one likes revisiting painful personal experience. But we do know that there are more patients who want to talk about these things than are able to talk about these things. And as doctors and nurses, we're very effective at blocking conversations if we want to, or if we're frightened or alarmed or concerned about going there. So I think that's a huge issue that we need not to force conversations on people, but be prepared to go there if they want to talk about them.
And certainly there's been a lot of evidence that's come out recently for the efficacy of earlier palliative care, certainly in terms of quality of life and even longevity for patients. So with that in mind, what sort of decision-making processes do you go through when deciding actually when to perhaps incorporate palliative care for a patient?
I think that's really interesting. You're right, there is interesting research that evidences that the earlier you get palliative care involved, the better quality of life people have, and actually interesting suggestions that actually people might live longer, which is kind of counterintuitive in some ways. And maybe that's because in part one of the conversations is around not pursuing aggressive treatment in a way that might not necessarily be helpful for the patient. When to start is an interesting question. There used to be a more sort of traditional model whereby when the cancer specialists had run out of treatment options, then palliative care was wheeled in. Cancer treatment is changing. There's much more in the way of treatment options when we can't cure people, but there is useful anti-cancer treatment. And so palliative care is much more integrated alongside what the cancer specialists do or the heart failure colleagues will be doing. So there is a move towards earlier, and there's a move towards making sure that it's something that every person involved in patient care is involved with. Yes, there is a specialty, but it's a task for all of us.
Do you think that's something that needs to be started earlier in medical education?
Really interesting question. We are relatively unusual in Cambridge in that we have a very highly developed palliative care course in the clinical years, the final 3 years of the medical course here. And compared to most other medical schools in the UK, it's much more comprehensive. And the goal is really to make sure that the doctors of the future, irrespective of what specialty they're in, understand the principles and the practice of palliative care. So one or two might go off and become specialists in palliative care, but what we want is the surgeons and the physicians and the geriatricians and the GPs being able to and comfortable with looking after patients. My research group has just very recently published a review of all the literature about junior doctors and palliative care, and the phrase is "in the deep end." And that's the summary of the literature: unprepared and thrown in the deep end. And right from day one, almost every junior doctor is going to be looking after and involved with patients. And so every medical student needs to be prepared. And it is hugely patchy across the country in terms of how comprehensive that is, unfortunately.
And I imagine if you want patients to be adopting a mindset of starting palliative care isn't the same as giving up and stopping all treatment. Yes. It's really important that doctors themselves don't have this attitude of, right, well, I'm a specialist. If I refer this patient to palliative care, that's me giving up and sort of admitting a defeat with a given patient. So fighting that attitude must be like a big part of that.
It's a real problem. So you're absolutely right that hospice is seen as giving up, and there's a public perception out there that if someone is admitted to a hospice, then that's it. And a lot of people are surprised, a lot of doctors are surprised to know that nationally, slightly under half of people who are admitted to a hospice do not die in that admission to the hospice. They're clearly ill and approaching the end of their lives, but a lot of people go into hospice and then go home or back to the care home or whatever. So it's not giving up. It's about optimising the time that is left when there isn't much we can do about how much time is left. But the public conversations around these issues, the public as a whole, tend to shy away from these. Although, as everyone said, there's only two things that are certain in life: death and taxes. So it comes to all of us, but somehow it's something we don't talk about. And that's an issue of the British culture. In other cultures, it's really quite different across the world.
And do you think that there are any other misconceptions amongst patients as to what palliative care entails?
I think there certainly are perceptions. It's about giving up. They think it's about morphine. There are huge concerns about morphine, and that when, as doctors, we prescribe morphine, that it foreshortens life. And there is good evidence that using appropriate doses, it does not foreshorten life. But there's a big fear. And there have been incidences where morphine has been misused and lives have been foreshortened. So that's another big fear. And then it plays into, there's confusion around palliative care and the whole euthanasia-assisted dying debate. And people can kind of confuse the two. So I think those are some of the common concerns that people have. And then it's overlaid, as you say, with us in the health professional roles kind of ducking these issues.
So just to clarify what we were speaking about then, that's we're talking about the use of medication to treat pain. Morphine.
Yes.
Yeah.
So, I mean, morphine is a dangerous drug, clearly, if used inappropriately, and we use powerful sedatives and other things. But if morphine is used as much as needed to control pain and no more than that, then actually there is good evidence that it does not foreshorten life. If we ridiculously increase doses of morphine, then it may well foreshorten life. But appropriately increased as and when a patient needs it, kind of keeping the pain under control is the focus. But there's a great concern that, whoa, that's going to hasten my loved one's end, where actually there is very clear evidence that it won't.
And I suppose if you put yourself in the shoes of somebody who might be suffering from like an incredibly painful terminal cancer, like you have to start thinking about quality of life as well as quantity of life, I suppose. Yeah, absolutely.
And the palliative care talks about focusing on physical, psychological, social and existential issues and embraces all of those. So for a lot of people, when they're approaching the end of their lives, it's not an easy thing. And it's not an easy thing psychologically. It's not easy at all to say goodbye to loved ones. And for many people, there's a bit of life review and what's my life been about. Whether or not they use religious frameworks, we all, when we know that we're approaching the end of our lives, have existential things. And palliative care tries to address all of those. So it's what we call multidisciplinary. So it's not just doctors and morphine, it's nurses, it's counsellors, it's chaplains as appropriate, etc., 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 supporting both patients and family.
Yet in contrast to this, the importance of good end-of-life care in ensuring quality of life, only 0.1% of research funding is actually dedicated to palliative care. Do you think that it's being recognised enough in the research setting, and there's enough research behind what is actually effective at the end of people's lives and what really matters?
Really important issue. So I think the spend in terms of services is one problem, because people judge services in terms of to what extent they make savings to the health service or stop people going into hospital. And in services for people approaching the end of life, you're probably not going to make any savings. And that's a challenge, because it's difficult to prove that this is cost effective, because people by definition don't live longer. But it's a quality issue rather than a resource funding, health economics issue. In terms of research, you are completely right that a tiny amount of funding is put into this, and certain areas of research attract huge amounts of funding and others are quite disproportionate. I pointed out to a group of professors recently that Cambridge has experts in rare diseases and world experts in really rare diseases. Cambridge does not have a professor of palliative care, despite the fact that it occurs in 100% of the population. And they were quite struck by that we research rare things but common things, and how to improve the pain, the care for people.
And I suppose one of the difficulties of thinking about quality of life and how much you can improve it at the end of life is that it really resists the same sort of analysis that normal quality of life entails. Like you said, there's this big existential component to coming to the end of your life, and how much of a difference does that make to improving the quality of that time and decreasing that sort of maybe existential fear.
Absolutely. And one of the real challenges of research in this area is how do you measure? Because the person you really, really want to know from is either very close to the end of their life or is sadly no longer with us. And so you can't ask someone after they've died, how was the last 24 hours of your life? Whereas we're super interested in that. You can ask the next of kin, the family members, but that's never as good as asking the individual themselves. So that's a real challenge. And what we do know from worldwide studies is that the UK is rated to have the best palliative and end-of-life care in the world. But we do know still that there's a huge amount of room for improvement. We're not doing as well as we could.
So I think this leads us on really well into talking about some of the specific issues of talking to patients at the end of their lives. So how does that position of power that a doctor has change when somebody's facing the end of their life? Like, do they look to you for sort of philosophical advice? And like you said earlier, does it change whether you're talking to somebody who's religious or not? So what's your clinical experience been like?
So I think these conversations are challenging because most doctor-patient conversations are actually the doctor or the nurse or other healthcare professional. We are actually very much in control, and patients come to see a doctor because they've got a sore throat and they want us to sort out what's going on and us to give them whatever might be appropriate or not for the sore throat, and they come to us for us to make decisions. But in palliative care, it needs to be much more controlled by the patient, and if they want to talk about things, then we have to be prepared to talk about them. And sometimes they will bring up issues which, frankly, as a doctor, are not necessarily my skill set. So I'm not a professional counsellor and I'm not a chaplain. But if people have issues, I'm not a social worker either. So thinking of the psychological, the social and the existential, often people will bring those things up. And sometimes it's beyond what I can address as an ordinary human being, and I need to get colleagues involved. And that's part of the multidisciplinary side of things. But there are occasions where people want to talk, and they want to talk to you now, and you saying, hang on, I'll get the counsellor in to see you tomorrow, just doesn't work. And that's one of the things that can be most challenging, is actually you kind of take off your white coat and you're out of the doctor role. It's one human being talking to another human being. And that is both hugely rewarding, but also potentially quite challenging. And relating to your comment about people with particular religious beliefs, there's an interesting research literature around that some people with strong religious beliefs find them hugely helpful when they're approaching the end of their lives. Other people with strong religious beliefs find them hugely unhelpful, because particularly if they have a kind of belief that if I live a good life, then the deity will be good to me, which is a kind of transactional religious belief that a lot of people do have fundamentally. Then if you're young, with young family, and it's all horrible and you're approaching the end of life, then the deities let you down. And sometimes I know our hospice chaplain spent a great deal of time encouraging people to get really angry with the deity in whatever framework they have, because that's okay. And it's actually important to be able to articulate that they feel utterly pissed off. Sorry, maybe I shouldn't use that word. Utterly let down by...
The podcast is not suitable for children.
But has full editorial control over our content.
But some people can find it hugely helpful. But it depends partly on how much they have this kind of simple, I'm good. If I live a good life, then the deity be good to me, because it's not quite how life works, sadly.
And speaking of these deeply personal relationships that doctors can have with their patients, can this at times put a strain on you as a doctor to actually be emotionally involved here? And what precautions perhaps do you have to take?
So the whole question of empathy for us as doctors and nurses is a real challenge, because one of our core things is we've got to have the patient at the centre of our attention. And if I'm too emotionally involved, perhaps because this is an elderly person and it reminds me of an elderly relative who maybe is going through something similar, and I get terribly upset, not because of the patient in front of me, but because of the person I'm thinking about, then that's unhelpful. And so we never want to be in a position that the patient is helping us and sort of trying to put us back together again. And there are times when sometimes if someone's really going through something really hard in their personal life, that sometimes they just need to gently step away and get another colleague in, because they just aren't able to do more than think about the horrible things that are going on in our personal lives. So it's that when the personal and the professional kind of collide, that's the delicate bit. And the important thing for the doctor is to be able to recognise when that's happening. And am I in danger of becoming over-involved with this patient and not thinking straight? Because when I stop thinking straight, then sometimes I can make unwise decisions. It's perhaps that difference between empathy and sympathy, where empathy is the ability to recognise what a person is going through, but to keep a degree of professional distance from that. Sympathy is where you kind of suffer with, and you kind of get in the hole that people are in with them, and you sort of, and then that's sometimes when you lose your thinking. It's a real skill to be able to be genuinely empathetic without crossing the line of then becoming emotionally involved. So I was talking to a cancer consultant specialist just yesterday, who says that she looks after young people with malignant melanoma, which is a particularly nasty form of skin cancer. And sometimes she says, when she's giving the really bad news that she has to do not infrequently, she says she sometimes does get a bit tearful. She never bursts into tears and loses control, but her perception is that patients really value that here is someone who recognises that you are giving me the worst possible news, and you recognise its devastating emotional impact, but you're staying in control. And it's a really difficult one. What is, I think, the doctor who's overly emotionally involved is dangerous. because they don't think straight. The doctor who is under emotionally involved, the sort of what someone has described as the mask of relaxed brilliance. In hospital consultants, you see that, the doctor who's very, very clever, very proud of the fact they're very clever, and never is affected or reflects on the horrible things that we see in medicine. And I think if we as doctors get to the point that or nurses, we walk away from a patient's bedside and, it's pretty horrible what you've seen, and it's water off a duck's back, then I think maybe you need to do some careful thinking as a doctor. I'm not asking you go away and burst into tears, but you probably would at times want to go away and just say to your colleagues, look, I'm just going to go and have a coffee. Or I'm going to go out and get a breath of fresh air because that was heavy.
I imagine another difficulty is balancing hope with realistic expectations about what people can expect. Now, from your perspective, does that require some sort of reading about how somebody will respond to different kinds of situations? So I imagine some patients would rather be told the facts as they are, and others, even if they don't say so, might actually not. And how do you sort of gauge that? Because once you've delivered information, you can't really take it back. You
can't. And I think that's a really important question. So I'll change the scenario for reasons of confidentiality, but I did have a patient who I knew probably 2 to 3 months away from the end of their life. And they knew that. And they came to see me to talk about having a big holiday abroad. And I sat there thinking that your holiday abroad that you're planning is in 2 or 3 months' time, and I don't think that will probably happen. And what do you do? Because one thing to do is to give them the hope that they've got and say, that's great, I'm sure in 3 months' time you'll have a great holiday. But I would argue that's giving them unrealistic hope. So what I did in that situation was to say, I think it'd be a really good idea if you have a holiday. Can I suggest you take it in the next month? And they realised what I was saying, which was, I'm not sure that we've got that amount of time. They went on holiday early, they had a great time, and by the time they would have gone on holiday, they died. And I would argue that at one level I took away hope, but another level I gave them back a realistic hope, which is, yes, you can have a holiday, but you need to do it sooner rather than later. And that takes a bit of courage, because that's a tough thing to say to somebody, and we sometimes don't get it right. But I think it's that difference between unrealistic hope and realistic hope. And some of the most difficult patients I find to care for, the people who are forever searching for, if I went to America, I could have some fancy cancer treatment, and I've heard that 1 in 1,000 people get better. And that sort of desperate hope, which can sometimes actually be unhelpful for people, because they end up going to America. Sadly, they're one of the 999, and then it all goes awful, and they're in America and they can't get home, etc.
Well, going back, perhaps not in that situation, but is there a danger that in treading around, perhaps directly confronting a situation, can lead to misunderstandings between doctors and patients as to what that situation actually is?
So I think it's got to be a patient-controlled conversation. I would argue that to a certain extent, a lot of medicine needs to be patient-controlled, and information giving, particularly of this sort of sensitive information, needs to be at the patient's pace. And if they don't want to talk today, or they don't want to talk to me, or they don't want to talk in this setting, that's fine, because often these are conversations over time. But if they do want to talk today, I've got to be prepared to go there. And one of the real skills is gauging how much a patient wants to talk and when they've had enough for today. Without going on too much, or without them feeling that you've cut them off prematurely.
And perhaps as medicine is seemingly becoming a little bit more impersonal, and actually some would say that we're losing this doctor-patient relationship and this continuity of care, is there a danger then that actually you won't understand your patient well enough going into these situations to actually make a judgment on what could be good for them?
You're absolutely right that the old-fashioned pattern of the consultant who you saw every time, or the family doctor who saw you from when you were a bump in your mother's Tom, until you were sort of, a parent yourself, etc. That longitudinality, that sort of long-term relationship is being eroded in both hospital and in the community. And we are losing something, which is that kind of trusting relationship that you've been through a few bumps in the road with me before. And now I feel I can trust you. And we are losing that, and medicine is becoming more impersonal. And we've lost something, I think, really important.
In terms of where this care is actually taking place, more and more people are dying in hospitals in the UK. How is the practice of palliative care affected by whether it's happening in a hospital or in a different setting? How does that change it?
Really interesting question. Interestingly, the number of people dying in hospital is very slowly reducing, which is interesting. For many years, it was more than 50% of deaths in the United Kingdom were in hospital. It's now slightly below 50%, but it is still the most common place for people to die is in hospital. The latest figures are about a quarter, slightly under a quarter die at home, slightly under a quarter die in care homes. Only about 6% of all deaths occur in hospices. So that's one misperception that's also out there about hospices, which is that they're big places that have loads and loads of people, and that large numbers of people die in hospices. They're a really important place for care, and they do a lot of care for people who die in other places. So it's hugely influenced that the busy hospital ward is noisy, and it's not a great place to try to get better, let alone not a great place when you're spending your final days and your family can't come and stay with you. Hospices are great, but they're not long-term places. The average length of stay in a hospice is just 12 days. So again, there's another perception that people can go into a hospice and spend the last 3 months of life there. For many people, that's because actually they pass away, relatively quickly. But for other people, we do need to move them on to back home or to a care home. Home is great if you've got adequate support. It's pretty grim if you haven't got adequate support. And GPs and district nurses are under pressure, particularly nights and weekends. And care homes, as you know, can be terrific places or can be less than terrific places. And you have to pay to be in a care home. And the whole question of finance of being in a care home is a challenge. So there are pros and cons for each of those 4 settings, and the quality of the care can differ according to those settings.
And on the topic of family and support at home, what sort of conversations are you having with people's families, or what sort of conversations are important to have, and to what extent should you factor in actually perhaps their interests as well as a patient's? Because after all, a patient's interests might be that their family is also supported in this scenario.
Yes, completely right. The primary focus of our care is the individual patient, but none of us are individuals. We're all individuals with important people around us. And so we will often spend as much time, if not more time, with the family and friends and other people. And that's an important part of our role. There are interesting questions around confidentiality, because I can't tell other people about a patient's condition without their permission to do so. Almost invariably in this setting, patients are happy, more than happy for us to do so, because they are one of the biggest concerns of people as they approach the end of their lives is what's it going to be like for my loved one left behind? And having a period of preparation, and for family members to even begin to kind of grieve before their loved one has died, can be really important. So big focus of our care is supporting family members during and then, of course, after their loved one has died. So you're absolutely right that it's important to include everybody.
I suppose one of the things that I imagine is quite difficult about palliative care is how patient decision-making can change over time. And patients with certain conditions can to some extent lose what we call the capacity to make decisions for themselves. And how do you navigate that? Like when somebody has capacity to make a decision and then at a later point loses that, but the situation has changed, do you respect what they wanted beforehand? To what extent do you have to worry about families, what family wants being differently aligned to what the individual wants? How do you deal with that?
Fortunately, in the UK, we've got very good legal frameworks around that. So when a person is able to make decisions for themselves, then what they decide is what happens. And if the family disagree, then it's the patient's decision. Patients can't insist on having treatment, but they can decline treatment. It becomes, as you say, much more tricky when the person maybe becomes very confused or becomes unconscious and is no longer able to make decisions, particularly if the situation has changed as well. And we would like to be able to ask the patient now, given that X or Y has happened, now what would you like us to do? And some patients can write something down in advance, and there are legally binding documents that people can write called advanced decisions to refuse treatment that have to be very, very specific. And people are able to say, if this situation happens, I do not want this treatment or that treatment. So I do not want ventilation when I get to the end of my condition on intensive care, even if my life is at risk. So, and that's legally binding. But after that, when someone has lost the ability to decide for themselves, lost capacity, as you say, is the term we use, then actually the decision becomes ours as the doctors. We have a responsibility to consult the family, but we do not ask the family what they want for their loved one. The question is to the family is, what do you think your loved one would have wanted? And sometimes the two get confused. And sometimes family are saying something that we think is not in keeping with the values that we think the patient would have had, in which case, ultimately, it's down to us as the doctors with colleagues to decide. So fortunately, we have what's called the Mental Capacity Act, which is the framework within which we operate. And one of the things you are not doing, and this is an important thing to say to family members, is you are not asking people to make decisions on behalf of their dying loved one. So the classic one is around whether or not someone should be for resuscitation or not. And they're unconscious, and the doctor comes and sees them and says, look, we think your loved one may be dying now. We don't think that we should be jumping up and down on their chest and resuscitating them should their heart stop. That is not asking the relatives to agree, because that feels like signing your relative's death warrant. It is actually just saying to the relatives, I am explaining to you what our decision has. So it's a sensitive explanation, rather than asking the family to make really big decisions that they may feel afterwards, well, it was my fault he died or she died. And that's a burden that is our responsibility, not the family's.
And do you think as medicine can do more and more and more at the end of people's lives, perhaps it's difficult for doctors and families to say no, and it's easier actually to say yes and bring a treatment in?
You're absolutely right that in years gone by, when some cancers when I was a medical student, when cancer of the bowel, for example, had spread to the liver, there really wasn't very much that you could do. There were 1 or 2 chemotherapy drugs, but if the growths in the liver were expanding, that was kind of it. But cancer science has improved so much that there are more and more treatment options. And one of the questions is for whose benefit is it to keep on and on and on treating? And it's becoming increasingly difficult to stop. And one of the guidelines is in cancer care is that patients in the 30 days before they died should have had anti-cancer treatment stopped. Although it's easy to be wise after the event, because it's often unclear that you're in those last 30 days. And saying to a patient, we're now stopping your anti-cancer treatment, is a tough thing to say. And is even tougher when some of the new treatments are just a tablet or a capsule that someone swallows. It's not necessarily as aggressive as some other treatments. So, well, can't I just keep swallowing my pills, doctor? And that's a tricky one. But you're absolutely right. that I was at a meeting in one of our hospitals recently where they review all the deaths in the hospital, and they thought they were going to find maybe what they were looking for was things that maybe could have been done better. Maybe we'd missed this or missed that, which they were looking at in a really helpful sort of self-critical way. The overwhelming message that came out was, why on earth did we continue for so long? And we're not very good, that hospital team was saying, and they're a superb hospital, at deciding when is enough and enough. And that's a really difficult one, because when you decide that enough is enough, you're talking about the end of life coming pretty soon.
And although this is actually quite a nasty topic, I'll bring it up anyway, which is that currently we're looking at an individual case in isolation. But the reality in the NHS currently is that quite a large proportion of people's healthcare spending over their lives, it comes in the last 6 months of their lives. So how do we balance, actually perhaps in cold hard financial terms, and in reality it's not cold hard financial terms, it's balancing one patient's care perhaps in a different area, perhaps a patient that needs a cataract operation with somebody at the end of their lives, when perhaps our normal values, for example, quality adjusted life years, which the National Institute of Clinical Excellence uses for determining whether a treatment should be funded or not. How do we balance these end of life decisions with perhaps decision at different stages in people's lives?
You're absolutely right. And these are really difficult decisions. So there's the whole communications, ethics, sort of people giving up hope conversation. But then there is then the added resources, issues as well, which one tends not to openly discuss with patients. I'm told that in the States, the commonest reason for bankruptcy is healthcare bills, just that people rack up enormous expenses in terms of healthcare, and they go bankrupt. And you're absolutely right that some of these newer treatments for some of these diseases, like cancer, are outrageously expensive. So you're prolonging life by a few months, and the drug is costing £3,500 a month. You're not going to cure the patient, but you can extend life by a few months. But that £3,500 per month is coming from a limited pot. And cataract operations or mental health services, which are the poor relation, are not going to get £3,500 a month in consequence, because it's not an unlimited pot. And how do we trade those two off? And for some reason in the British society, the argument to be funding cancer treatments kind of wins. That if you can extend life with cancer, who's going to say no, because cancer has such a strong emotive appeal. But dementia services and mental health services are just really the poor relation. And is that right? And the answer is no, it's not. But I don't have a solution to the problem.
And on the topic of prolonging life, should we take an extra month's worth of life as a sixth of the value of 6 months worth of life? Because obviously that month, a lot can happen in that. It can be such an important time for a patient and for their family as well, that it seems perhaps inappropriate to compare it and to compare just time.
I mean, an extreme example I heard about, and again, I'll change things in terms of confidentiality, was a person who for various reasons was losing a lot of blood and needed to have really quite a number of pints of blood to keep their blood count up. And they knew that the end was really close, but they had some really severely broken relationships with family that they wanted to mend. And the decision was made with them that we would continue transfusing for a couple or 2-3 more days, in order that the estranged family members could come over and there could be some reconciliation. And when that was done, and it was all very bittersweet, as you can imagine, the patient then said, thank you, I'm happy now for us to stop the transfusions, but said, those last 3 days have been the most important days of my entire life. And at one level, we were just wasting blood, because, it wasn't doing any good. It was going in the vein and they were bleeding. But at another level, we bought them some really important days. And it's at an economic level, you would say this is a nonsensical thing to do. At a humane level, you would say it was a no-brainer. Of course we do it.
I hadn't realised that doctors were allowed to make those sorts of decisions in terms of weighing up those sort of the emotional content to in a very specific situation.
Yeah, and that was a very extreme situation, but yes, we can. And yes, you may get the blood bank breathing down your neck and asking you what on earth you're doing, because this is the 6th pint of blood in 24 hours for this patient. And you may get the managers breathing down your neck saying, this person needs to be out of hospital. But sometimes as doctors, we just need to say, I'm really sorry, but sometimes we're the patient's advocate. And in that situation, it was clearly, without question, the right thing to do. It was a fairly extreme thing to do, but was a very memorable thing for the entire ward that this patient was on. They knew exactly what was happening. Everyone agreed it was the right thing to do. It was lunacy in terms of use of resources, but it was completely the right thing to do for that patient. And yes, we are sometimes able to, and sometimes we do, we go out on a limb. And we say, if you need to be the most senior doctor, when you've just qualified, you don't make these sort of decisions. But the consultant in that case just went and talked to the blood transfusion consultant who said, yeah, I totally agree. You're doing completely the right thing.
As a doctor, do you need to build up a good almost reputation so that people will take you seriously in those sorts of situations? Is that something you think about?
Interesting. Yes, you do. If you're known as a maverick who does crazy things every day of the week, then when you find yourself in that sort of situation, you're not going to be taken seriously. But if you're known as a doctor who can never, ever have these difficult conversations and say enough is enough, then they're just going to say, oh, there goes Dr. X again. And he's always, or she's always doing this. But if, oh, blimey, you've not done this before. And they respect you as someone who makes sensible decisions and isn't afraid of sometimes saying to people, I'm afraid, no, we are now stopping. So you're right. So
build up a good reputation as the decision maker, and it sort of helps you in palliative care.
Absolutely. And that cuts across the board, so that, if you want someone to do you a favour and fit in an extra person onto the operating list because, you've got an extra patient with an appendicitis, if they know that, oh, you're forever doing this, then they'll probably say, no, wait until tomorrow. But if they say, oh, okay, yeah, then, that's the way medicine works. That's the way much of life works is, it's that broader team thing. Yeah, yeah.
And how important, leading on from that, is the support from colleagues that you can get in making these decisions?
I think in terms of whenever there's anything that's remotely or potentially controversial or very emotionally charged, where you think, am I thinking with my heart and not my head? I think it's really important to always sit down with someone and say, look, this is what I'm thinking of doing. Can I just run this past you? And it may not be a good friend. It may be someone when you're a junior doctor and you're in an area of the country where none of your colleagues are. But it's a skill one needs to learn of saying, look, can you just tell me if you think I'm being completely irrational here? There are a series of doctors who've got into trouble because they've made unilateral decisions without consulting colleagues. And any colleague would have said, what on earth do you think you're doing? No, don't do it. And so I think in any of these situations, yes. These are rarely individual decisions, but it's a wise doctor who just an alarm bell goes off thinking, I need just to do a sense check here. Because particularly when it's getting very emotional, and if there's young people involved and there's young children involved, and it is easy to actually stop being rational, and as I say, thinking with your heart rather than your head, and then you can make unwise decisions.
And on one hand, we've got the prediction perhaps that the introduction of AI into medicine will free up doctors' time for actually having these challenging conversations. But this is balanced again by actually funding cuts within the NHS and really high occupancy rates in hospitals as well. Are we perhaps cutting short these conversations at times as doctors because actually people are too busy and the pressures are there, and we aren't able to have these really important discussions?
You are completely right. Interestingly, one of the commonest reason for complaints in the NHS relates to care towards the end of life, and it is almost invariably around failure to communicate adequately. the public on the whole generally assume that we've done a technically competent job. Sometimes clearly we fall short. But as I say, the commonest reason for complaint is my loved one died in hospital and there was inadequate communication. And you're completely right that people are increasingly under pressure, both in general practice and in hospital. And when you've got 35 patients to get through that morning, you can't give them more than 30 seconds each before you go in to do your operating list. And it's the system that we're working in.
So with that in mind, and perhaps with an eye towards the future, is there anything that you would like to see introduced in palliative care?
I think the most important thing I would like to see introduced is that all medical students and all doctors have had some education in palliative care. I think you talk about the classic knowledge, skills and attitudes. Now, the knowledge is relatively easy to learn about how to use morphine and other things. The skills of communicating that we've been talking about are more subtle. The underlying thing is the attitude that, and if in this medical school we have 300 students a year who have an attitude towards palliative care that is not that this is the world's worst, most heart-sink situation, but that it's something I feel confident and competent to deal with, so that when you step behind the curtain and you recognise, whoa, Mrs. Bloggs has deteriorated, and I think we're now in the last few hours of life, you don't run like a frightened cat not knowing what to do. So you step forward and say, okay, I know what to do here and I know what the situation is. And I said earlier that right from day one I had an email, and I'm sure they won't mind me saying, this summer from one of our students who had just qualified, had been a junior doctor for all of 1 week, wasn't particularly interested in palliative care as far as I was aware, but he said within his first week he had 3 patients die, 2 of whom he'd had to have a conversation with the coroner because they'd had operations and there were technical things there. But he said his first ever night on call, he was bleeped by the nurses at 7 o'clock in the evening to say, there's a family here, their loved one is dying and they want to talk to a doctor. And he said, there was I, a shiny new doctor of 4 days. And he said, I had to explain to them that their loved one who he'd not met before was dying, and why they were having this funny breathing and what the drugs were in the syringe driver. And he said that man, or it was a man or a woman, I forget now, but the patient died that night. And he said the thing that was most touching for him was when the family came back the next morning to collect the certificate and their loved one's belongings, they actively sought him out to say thank you for doing such a great job. So any doctor needs to be able to think, when the family rings up to say, or there's a message to say, can you have a conversation, doesn't think, oh my goodness, I don't know how to do this, but think, okay, I've had some education in this.
I think on quite a sensitive and emotional but such an important topic, that's quite a nice positive note to end on for today. So Dr. Barclay, thank you so much for talking with us. It's been a
Pleasure.
fascinating conversation.
Thank you so much.
Thank you. Thank you.
Thank you for listening to the Pager podcast. If you've enjoyed it, then head to Spotify or iTunes to hear more.
As ever, we'd love to hear what you think, and you can reach us via our Facebook page or by email. See you next time.